Hello and welcome to HD Live, the streaming video service of Health Day News. I'm Mabel Jong. As the start of classes inches closer, more and more colleges are announcing their plans for the fall semester. The College Crisis Initiative out of Davidson College in North Carolina has been keeping track and says of the approximately 3,000 colleges and universities across the country, about 500 schools are currently saying they will either be fully in person or mostly in person. Two experts join me, and they say the key to doing safely the return to campus is a lot of COVID-19 testing. Here now are Dr. David Paltiel from the Yale School of Public Health and Dr. Natasha Martin, an infectious disease modeler from UC San Diego School of Medicine, leading the Return to Learn program. So great to see you both.
Hi, Mabel. Good to be with you.
Well, Dr. Paltiel, let's start with you. Your models show that testing students, even if they're not exhibiting symptoms, will need to happen once every 2 to 3 days. Why is that optimal?
We looked at lots of different scenarios. We looked at lots of different performance attributes, how frequently the test produces false positives, how frequently it produces false negatives, how frequently it's used. And of all those variables, frequency turned out to be the most important variable possible. And, if you're trying to understand why that might be, a lot of it has to do with the asymptomatic spread of the disease and the fact that it can be transmitted by asymptomatic so-called silent spreaders. It's very hard to play catch up with this virus. You want to get out ahead of it. And the best way to do that is to screen with high frequency.
Okay, and you're also proposing screening with a lower quality, less expensive test.
Right.
What's the risk of that?
What we found, and what has been shown by many other people recently, is that frequency makes up for a world of sins with regard to the inaccurate and imperfections of the test. So given the choice between a test that was pretty sensitive and pretty good that you could use every 2 days, or a much more sensitive, more expensive test that you could only afford to use weekly, you would choose the first option.
Dr. Martin, let me bring you in here. Your Return to Learn program has been in place since May at UC San Diego. How does it work?
Thanks. So the Return to Learn program actually has three main pillars. One is reducing and mitigating the risk of transmission on campus. So those are things like encouraging students to mask, practice social distancing, sanitation. And we've also been looking at structural things we can do on campus to reduce the risk of transmission, like reducing classroom sizes and having some classes online, and changing the configuration of our dorm and housing situation to reduce the risk of transmission. The second pillar incorporates our viral monitoring, and that's where the testing piece kind of is embedded within that. So we want to be able to detect outbreaks early on campus. As Dr. Paltiel mentioned, asymptomatic transmission is very important. And so part of our early outbreak detection program is an asymptomatic testing program to try to detect outbreaks as early as possible. Embedded within that viral monitoring is also wastewater monitoring. We'll be monitoring the sort of wastewater from dorms and residences to see if that can help us also give us an early signal in terms of if there's viral activity or infections within a specific dorm. And then we can go in and do more widespread testing to identify those infections and act on them. And then the third pillar is public health intervention. So that's isolation of cases, contact tracing, and quarantine of those contacts to ensure that any infections don't continue to spread in our population. So that's our overarching strategy. Now, in May, what we started was a smaller pilot program that really just looked at that asymptomatic testing piece. We ran a 3-week pilot among residents that were students on campus at the time, just to try to understand the acceptability of testing and whether we could provide self-collected tests. The students could collect themselves, and we could set up an easy way for them to access testing, get the test process, the test results back to them in 24 to 48 hours on their mobile phones, and kind of really streamlining it so that we could then in the fall, when our students return, initiate a periodic testing program at a larger scale than we had in the summer.
Okay, do you think you're prepared with the correct or accurate information that you need to have a fall opening that is successful based on what you've been doing over the summer?
So we've always said that our approach would be adaptive and that we take the information as we learn and we'd adapt the approach as we go. We've started with, so students will be tested when they return to campus. And then, as I mentioned, after they return, we'll start our periodic testing program in the fall. We're aiming for monthly testing in the beginning. That was based on our simulations indicating that that level of testing would allow us to identify outbreaks early. Again, I think that the sort of strategy at Yale is fantastic in terms of using testing to prevent transmission, but we want to detect outbreaks early, and we feel like we have the test capacity and the situation in place to do that.
Okay, back to you, Dr. Paltiel. Is the testing strategy that you're focused on doable at most universities across the country? 2 to 3 days of testing?
Yeah, I realize that we are setting an exceptionally high bar. The recommendations that emerge from our analysis are logistically complicated. They are financially burdensome. They may well be psychologically intolerable, both for administrators and for students. In all, they may very well be beyond the capacity of many universities and the students in their care. But, you know, our point is that just because something is hard to do or not terribly practical or infeasible doesn't mean it isn't important. At the end of the day, I think we're trying to help colleges and students and families to understand what it would take to keep the campuses safe. And if they can't see their way toward meeting those minimum standards, they really need to ask themselves if they're ready to reopen the campus.
Mm-hmm. Dr. Martin, your approach, your model is quite different from what Dr. Paltiel has been working with. Would other universities be able to replicate what you're doing in San Diego?
Well, we are also fortunate to be paired with a medical system where we can get a high volume of PCR tests run at relatively low cost locally, and our sort of return in terms of those tests is within 24 to 48 hours. So we are fortunate in that, and there may be, there are many other institutions which don't have the ability to do that. But I think the idea, the concept of asymptomatic transmission being important and having some amount of asymptomatic testing in order to monitor and prevent, identify outbreaks early and prevent transmission is an important strategy.
Yeah, and I want to second that. I don't, there may very well be some distinctions between what Dr. Martin and I are talking about, but I think the areas of overlap and the general qualitative view that one has to hit this early, hit it hard, recognize the silent spreaders, test frequently, stop an outbreak in its tracks before it starts, recognize that nothing you do is going to be perfect, and therefore you're going to have to both set aside sufficient isolation capacity and have an exit strategy. All those things are commonalities. Ultimately, my model isn't taking sides, and I have to imagine that neither is she. We're both looking for the ways that we can keep campuses safe and provide sufficient information that university administrators, students, families, and by the way, members of the surrounding community who may very well be the most at risk should something go awry, can all make an informed choice.
Right. Now, are residential college campuses in some ways well suited to handling a pandemic?
Well, some people have referred to residential colleges as cruise ships on land. I'm not sure that's a terribly good metaphor because these things make stops at many ports of call, and lots of people get on and lots of people get off. I think that you have to recognize that in some ways they are terribly ill-suited to the extent that everyone is living in close quarters, eating together, sleeping in the same places. On the other hand, it is a structured environment, one that can provide a certain amount of diversion, structure, organized, sympathetic, low risk kinds of social events. Mostly I want to say that having students return to college to live under the imperfect supervision is a risky prospect. But then again, having students stay home to live under the imperfect supervision of their families is also a risky prospect. We want to take note of the fact that the problem of student-driven transmission does not go away simply because you close campus. We mustn't let the perfect be the enemy of the good. We're doing our best to make it as safe as we can.
Okay, certainly many benefits to this all working out. Dr. Martin, is it inevitable that we will see outbreaks, and to what extent will they cause colleges to close again?
So I think it's inevitable that we will see viral introductions on campus, and particularly campuses where we have a large proportion of our students maybe living off campus. And so we are aware that that is going to happen. And I think what we want to do is try to prevent transmission on campus and try to be able to react accordingly and try to keep the campus, safe or safer than the outer community environment. And we don't want to exacerbate it by what's going on campus. So, as we see increasing incidents in the community and we see this introduction of viral infections, we need to be ever vigilant to make sure that we are able to respond and accordingly and detect those infections and isolate them and prevent any further spread on campus.
Mhm. In both scenarios, a lot of testing. What about the students? Could you perhaps lose the faith of students in this process if there's too much testing or perhaps too many incidences of false positives?
So we've done a lot of qualitative and quantitative work among the students that were in our pilot, as well as students and faculty subsequently about this issue. And one of the very strong messages that we learned from them is that they wanted to know that this testing was part of a broader public health good program, that it was something that everybody was engaged with to keep the campus as safe as possible and to enable some amount of in-person activities on campus. They were less interested in the idea that they would know their status or that they would be testing for themselves, and they really wanted the message to be about the broader public good, which it is. We're trying to do testing in order so that we can have some amount of in-person campus activity and reduce that risk.
Mm-hmm. And Dr. Paltiel, what kind of training or approach should campus health services take on as we look at more testing on campus and dealing with students who might have questions on the validity of such tests?
Right. Let me answer that in a negative, what they mustn't do, and then move more to the positive. And by the way, I want to second and endorse everything that Dr. Martin just said. I think that those strategies are exactly what needs to happen. The schools can't just hand out a mask and a bottle of hand sanitizer and maybe a leaflet and wag their finger at the students and say, behave. That's setting them up to fail. And it's also setting them up to be scapegoated at the end if something does go awry. You have probably read just as many papers as I have about the 20-year-old brain and how it isn't neurologically wired to make an appropriate weighting of risks and benefits. I get that, but that's not their problem. That's our problem. We're the grown-ups in the room. We have a responsibility to provide them with resources and with imaginative, compassionate, realistic, low-risk options to stay socially connected, to get the human interaction that they richly deserve and that they need, and to make the on-campus social event sufficiently attractive that it discourages them from wanting to head down the road to do jello shots in the basement of the frat house, which is what I really want to make sure I avoid. I'm not trying to avoid every single infection. As Dr. Martin pointed out, they are going to happen. I'm trying to prevent an outbreak.
Okay. Should doctors and healthcare workers use specific types of language, perhaps, to continue pushing the correct message about the social distancing, the masking, the testing? What's your
Yeah,
advice there?
and there's a tremendous amount of literature. I'll point your viewers to work by Julia Marcus that has been published recently in the Atlantic magazine, precisely on the question of turning this into a positive thing rather than shaming, and the importance of bringing students on, as Dr. Martin said, as partners in this venture, rather than as the enemy that needs to be tamed or the neuron that needs to be, suppressed.
Mm-hmm. What is your best case scenario out of this? I want to present that to you both. What are your models saying is the best case scenario? You want to take that first, Dr. Martin?
Yeah, I mean, I think the best case scenario is similar to what we're trying to achieve in society, and to understand that opening campuses, like opening any other part of society, there is risk inherent in that. And what we want to do is reduce that risk. And so again, like we've been saying, acknowledging that if we, bring students back on campus, we'll see some infections, but we want to reduce the risk of that, reduce the likelihood of large outbreaks on campus and be able to mitigate that risk. I don't think there's we at at UCSD do not have an absolute number or metric that we're going for in terms of saying this was a success or a failure. We want to be able to sort of adequately test and ensure we have adequate isolation housing and everything's in place so that we can do the best we can, acknowledging that any amount of reopening inherently has some risk.
Mm-hmm.
My difficulty is that many schools are planning as if everything that could possibly go wrong is going to go right. They're not giving themselves enough wiggle room. I have a background in engineering. We build bridges to withstand many times the weight that we expect them to bear. Bridges that can only bear the weight that we expect them to bear go by the label house of cards. I urge, and that's why I was so pleased to hear Dr. Martin describing an adaptive approach, one that starts cautiously and then takes stock of matters before deciding to dial things back. And I'm sorry, I'll just take one more moment to mention that what really is concerning me is the many schools out there that are considering the option of not doing any testing, but of simply monitoring students for symptoms of COVID and using those signs and symptoms of illness to trigger testing, isolation, contact tracing, and quarantine. We explored thousands of scenarios in our simulation model, and we did not find even one plausible circumstance under which that strategy would be sufficient to contain an outbreak, again, because of the silent spreading and because you simply cannot catch up with this virus. And I'm deeply concerned that many schools, which are planning only to respond once symptoms are observed, are behaving as if they were fire departments that only respond to calls once the house has been reported to have been burnt to the ground.
Okay. So do you see a scenario where schools will need to close again?
I certainly have been able to model such scenarios. They are within the realm of possibility. Again, as a betting man, they won't have, my money's not on those scenarios, but they are possible. And I do think that every university needs to plan its exit strategy and to say, to have a criterion that says, this is when we are out of control and really need to move to the plan where we shut the school down, send any students who can be sent home, hold on to the ones who can't go home for one reason or another.
Mm-hmm. And Dr. Martin, do you have a final word you'd like to add as well?
No, I just think that we all need to be, really vigilant that the community situation is changing week by week. We're seeing that in San Diego. So, that in terms of campus reopening, campuses need to be thinking about what their capacity is on campus, but also what the situation is in their local community and really assessing it week by week to ensure that they feel like they're in the right position to reopen.
All right, Dr. Natasha Martin of UC San Diego School of Medicine, also Dr. David Paltiel of Yale School of Public Health. Thank you to you both.
Thank you.
For more health news, remember to check us out at live.healthday.com, on our Facebook page at Health Day News, and on Twitter at Health Day Tweets. I'm Mabel Jong. Have a safe and healthy day.